Good afternoon and welcome everyone. My name is Melissa McVie and I am the Education and Home Support Facilitator with OARC. Just wanted to say thank you for taking the time to participate in today's live webinar, where we'll be discussing the topic of fracture prevention in long-term care. Now, before we jump in, I wanted to go over a few quick housekeeping items. Firstly, you'll notice that we've muted all the lines to eliminate background noise and distractions for our speaker today. This webinar is also being recorded for education purposes and will be made available to you following the session. We have protected time for a question and answer period at the end of our speaker's presentation, at which point you can either unmute your own line or you can type into the chat box, which is located at the bottom of your toolbar. Today's webinar slide deck is also available to you under the materials section of that same toolbar. So without further ado, I'd like to welcome our guest speaker, Caitlin McArthur. Caitlin is a registered physiotherapist and postdoctoral fellow at McMaster University in the Jarrah Center for Aging Research. She is also a lead instructor of the continuing education course Bone Fit, which teaches exercise and rehabilitation professionals how to work safely with people with osteoporosis to help prevent fractures. Welcome, Caitlin. I'll hand it over to you now.
All right, thanks so much, and thanks for having me here today. I'm really excited to present on this topic. So we'll just jump right in. So first, I'd just like to acknowledge all of the people involved in developing some of the material I'll be presenting today. So people involved in developing the fracture risk scale that I'm going to be talking about, my colleagues at the Jarrah Center for Jarrah Center for Aging Research, and along with that, the osteoporosis strategy team, and all of the researchers involved in developing the fracture prevention recommendations I'm going to be talking about today. So first, let's just talk quickly about osteoporosis and what it is. And basically, osteoporosis is a disorder or a disease where your bones break more easily than if you didn't have osteoporosis. And this is for a couple different reasons. First, it's that there's less bone than there normally is. It's not quite as dense as it is in normal bone. And also there's decreased quality. So the bone itself is actually a little bit different as well. And the most common body areas to break a bone as a result of osteoporosis are the hip, which a lot of people have heard of before, but also the wrist and the spine, so those little bones in your back, as well as the shoulder. And these are kind of the most common body areas that people who have osteoporosis will experience a break or a fracture. And when do these broken bones happen? So the most common reason is usually because of a fall. And the most commonly broken areas of the body with a fall are either your wrist. If you put your hand out to kind of stop yourself from falling and you land on your hand, you're likely to break your wrist. Or if you kind of fall sideways or backwards, or when you put your hand out, it doesn't quite absorb all of the shock from the fall, then the hip is also a very common place to break when you fall. But with osteoporosis, broken bones can happen for other reasons as well, such as repetitive slouching or poor posture. So kind of sitting in a bent forward position or just kind of staying in that posture for a really long time can actually result in a broken bone in the spine. Moving in the chair or bed, depending on what kind of movements you're doing, like twisting can sometimes be an issue rather than rolling like a log. And sometimes even something as simple as a sneeze or cough can cause a broken bone either in the spine or in the ribs. And why are we talking about broken bones? Why do we care about this today? And the main reason is because they are a serious problem. So about 2 to 6% of residents in long-term care experience a broken hip each year. And those broken hips are the most common type of fracture, common type of break in long-term care. So most fractures, or most broken bones that happen in long-term care are of the hip. And there's very significant consequences with a broken hip, like pain, disability, decreased quality of life, and it can result in being transferred to the hospital and even in death. And what's really important to note is that a lot of people who are at high risk for fractures or high risk for broken bones, they're not investigated or treated for osteoporosis. So about 75% or 72% of people who are at high risk are not investigated or treated for osteoporosis. And fractures can be devastating for long-term care residents. They can result, as I said, in pain, disability, so losing the ability to move around on your own, maybe going from walking to having to move around in a wheelchair. It can result in being transferred to the hospital, surgery might be required. So it's really important that we try to prevent them because they are quite devastating and can be a big problem. So how do we determine if someone's at high risk for a fracture? So there's two different ways that are used more commonly for people who live at home or in the community. And those are called the CAROC or the FRAX. The problem with these are they aren't really tailored for use in long-term care. So they were designed to be used for people in the community. And they rely on something called bone mineral density. So this is basically, it's like a fancy x-ray. It's called a DEXA scan that's done of usually your hip or your spine. And it tells you how dense your bones are, so whether they're at risk for breaking or not. And what's not really realistic sometimes is in long-term care to have one of these bone mineral density tests, because you have to leave the long-term care home, you have to go to a special place and then have this test done. It certainly can still be done, but it's not always common practice, and there's lots of barriers to it. The other thing that the FRAX and the CAROC rely upon is other things like age, sex, how much you weigh, any reason that you might have osteoporosis for a secondary reason. So this would be like rheumatoid arthritis or celiac disease or other reasons why your bones might be affected. And so things that aren't necessarily kind of collected in long-term care. So our team of researchers and clinicians who work in long-term care developed something called the fracture risk scale, or the FRS. And the point of the fracture risk scale is to determine or decide if somebody is at high risk for fracture, and then just knowing that they're at high risk for fracture, we can put strategies into place to hopefully prevent those fractures from happening. And this is a fairly new tool. It was developed about 2 years ago, and within the last year or so, it's gotten into the electronic medical records that are used in long-term care homes. And I'll talk a little bit more about it now. So I'm going to call the fracture risk scale the FRS from now on. It's just a nice little short form to use. So the benefits of the FRS are that if we use it, we can help prevent fractures. So we can stop those broken bones from happening, hopefully before they happen, and improve quality of life for residents and improve the care they receive, because we'll know who's at high risk and identify who should be receiving appropriate treatments to prevent those risks. So the FRS scale, it was developed to predict hip fracture for long-term care residents, so broken hips, but it also, we did another study where we looked at, does it also predict other fractures like spine fractures and wrist fractures and shoulder fractures? And it actually does a good job of predicting those too. It doesn't require any additional documentation or resources. So it's calculated based on routine assessments that are already done in long-term care every 3 months. So nothing else needs to be done. It's things that are already collected and already being done as part of routine practice. And it also doesn't require a BMD test or a bone mineral density test. So that was that special X-ray called a DEXA scan that I was talking about. So it doesn't require somebody to leave the home and have one of these tests done, or someone to come in the home and have to do this test. It's just calculated on routine data that's collected every 3 months. And the other thing is it's been validated across Canada. So we developed it using data from Ontario, but it actually works in long-term care homes across Canada. So you can use it kind of in any province. So what is the FRS score? So basically, you get a score from 1 to 8, where 1 is the lowest risk for fracture and 8 is the highest risk for fracture. So people who are at low risk, this is a score from 1 to 3. That's about 55% or just over half of the people who live in long-term care are at low risk. And then people are at high risk, or a score of 4 to 8, that's about 45% or just under half of the people who live in long-term care would be at high risk. Now, what do these people look like? What would their characteristics be? So people who are at low risk can walk and they might be overweight. So they're basically, we look at something called a body mass index, which is how tall you are and how much you weigh. So if somebody's overweight, they're actually at a lower risk for fracture because there's more cushioning. Or they would be unable to walk, so perhaps they use a wheelchair or they stay in bed, and they have not fallen in the past month. These people would be at low risk. People who would be at high risk would be people who have different characteristics. So they walk in the corridor independently, and they have a normal weight. And then they also have one of the following things. So they have either fallen before, or they've had a fracture before in the last 3 months. They have cognitive impairment, so have difficulty with memory and following directions. They would have a tendency to wander, so kind of walking without a clear purpose. And they would be over the age of 85. Or another scenario is that they would be unable to walk. So again, maybe they use a wheelchair or they stay in bed, but they've fallen in the past month or so. One other scenario that is high risk is if somebody walks by themselves and they're underweight, so they're quite slim, and it doesn't matter if they've had a fall or not. So if they're walking by themselves and they're underweight, they're at a high risk for fractures in the next year. And so the FRS score really predicts if somebody will have a fracture in the next year or so, whether they're at low risk for having a fracture in the next year or high risk for having a fracture in the next year. Now, I should say when we developed the fracture risk scale, we looked at all sorts of different characteristics that are included in that routine assessment. And these were the ones that were the most important, the ones that really predicted if someone was going to have a fracture or not. So let's put this into practice and see what it might look like in real life. So, for example, somebody like Mrs. Andrews would be at high risk because she walks independently by herself throughout the home, but she has a low body mass index. So BMI stands for body mass index, which means she's quite thin. And she's had a fall in the last little while as well. She would be at a high risk for fractures. Somebody like Mr. Anderson, on the other hand, would be at low risk. And that's because he uses a wheelchair to get around, so he's unable to walk, and he has not fallen in the past 30 days. So he's at a low risk for fracture in the next year. And then lastly, somebody like Mr. Tedeschi would be at high risk because he walks in the corridor with assistance of his walker, His body mass index is between 18 and 30, which is basically has a normal weight. And he's over the age of 85. Also, he has cognitive impairment, and CPS, that stands for Cognitive Performance Scale. And this is another scale, kind of like the FRS, that describes how much cognitive impairment somebody has. So this would be somebody who has difficulty following directions and might have some memory issues. Now, just some cautions when we think about using the FRS. It assesses the risk for hip fracture, but it might actually underestimate the risk for spine fractures. And why this is the case is because often spine fractures in long-term care don't come to the attention of the medical team. And this is because sometimes people might already have back pain, and the back pain maybe got a little worse, and it's hard to know if it's because of a spine fracture or because of something else going on. And the other thing is sometimes spine fractures don't actually result in pain. So sometimes they don't hurt. They're just kind of there. People don't know they have them. Or they have other symptoms like their stomach starts to feel a little bloated. Maybe it's a little bit harder to take a deep breath, but there isn't necessarily back pain. And so sometimes it's hard for the team to know that a spine fracture is there. Also, the FRS calculates this risk based on variables or characteristics that are available in that routine assessment that I talked about that's done every 3 months. And other factors might exist that aren't in that assessment, but we really developed the FRS using that assessment because we wanted people to not have to gather any other information, just be able to know their fracture risk, whether it's low or high, based on this assessment that's already done. So where can your care team find the FRS score? So where could you help them look for it or tell them that it's there? So right now, only homes that use point-click care as their electronic medical record, or they might call it PCC, are able to see the FRS score. So they have to go into the assessment, that routine assessment that is done every 3 months, and look at something called the Outcomes Summary Report. And at the bottom, it will say fracture risk score, and then it will have a number between 1 and 8. And 1 to 3 is low risk, and 4 to 8 is high risk. So you can direct your care team to look for this number there so that you could know your risk. So now we know your fracture risk score, your FRS score. Oops, sorry. What can you do to help prevent fractures? What do we know is kind of effective at preventing those fractures from happening? So the next little section I'm going to talk about comes from fracture prevention guidelines that were developed in 2015, and they were directed at the interprofessional team in long-term care, so including families, residents, the doctors, the nurses, the physiotherapists, the exercise providers, everybody kind of involved in care within long-term care. And what's really important is that they integrate osteoporosis and falls assessment in management to reduce fractures. So remember at the beginning I talked about what osteoporosis is. So it's having less bone or less decreased quality of bone. But a lot of fractures happen because of falls. So we wanted to make sure that we talked about how to prevent falls as well as treating osteoporosis. So how we want to interpret the recommendations. So I'm going to be talking now what they are for calcium and exercise and medication, but the words I use will tell you how strong the recommendation is. So a strong recommendation, which means there's lots of evidence for this particular topic, whatever it might be, I'll say we recommend. And basically this means that for residents, most individuals in this situation would want the recommended course of action, and only a small proportion would not. So most people would want to do whatever is recommended, but there are a few that would not as well. Now, if I say we suggest, this means it's a conditional recommendation, and the evidence here is not quite as strong. So this means that the majority of individuals in this situation would want the suggested course of action, but many would not. So it's a bit more, it's not as clear when we say we suggest, and that's because the evidence is not as clear. And before we jump into what the recommendations actually are, what is the goal of the recommendations? What are we trying to do? Well, first of all, we're trying to prevent fractures, but why do we want to do this? And as I mentioned at the beginning, fractures can cause a lot of issues like immobility, pain, and transfers to acute care or to the hospital. So we're really trying to reduce those bad things from happening. And our goal is to improve the quality of life for residents in long-term care by preventing these things from happening. So the first thing is we want to treat residents who are at high risk. So I'm going to talk now about what we want to do for people who are at high risk for fracture. So here's just an overview, and we'll go through them in a bit more detail in a second. The first is to do with calcium, as well as vitamin D. So calcium, we'll talk about it in a second, but preferably you want to get it from your diet. And then if that can't be achieved, you can take a supplement. With vitamin D, it's really hard to get enough vitamin D from your diet, especially at this time of year. It's hard to get it from the sun because it's not very sunny outside, and the sunlight is not direct. Also, if you're not spending a lot of time outside, it's hard to get enough vitamin D. So usually people have to achieve this through a supplement. For people at high risk, medications should be considered to treat osteoporosis and prevent fractures, and this should be a consideration that's taken on by the whole team. So resident, family members, the whole care team should really discuss this, talk about pros and cons to different medications, the side effects. You also have to look at kidney function and other things like that to make sure you're getting the best medication for you. And then promote exercise for improving balance, strength, and function. And as a physiotherapist, this is the part that's nearest and dearest to my heart. And I'll talk about what that actually looks like in a second. And then implement fall prevention strategies overall. Consider hip protectors, as these have been shown to be effective at preventing fractures. There are lots of issues with them, of course. They're not necessarily very comfortable, and they might not be appealing to wear, but they do help prevent fractures. And then working as a team with everybody to meet your care needs. So making sure that all of these things are being met, and that really your preferences around these different items are included as well. So let's talk about calcium a little bit. So for all residents, high and low risk, we recommend dietary interventions to meet the recommended dietary allowance for calcium. So that's basically how much calcium you want to try to achieve in one day, RDA we call it. And remember, when we say we recommend, this means that it's a strong recommendation. So there's a lot of evidence to support it. So for people over 70 years of age, the recommended dietary allowance for calcium is 1,200 milligrams per day. And this basically translates to only 3. My goodness, 30 would be a lot. 3 servings of dairy or dairy equivalents per day. So that would look something like a yogurt, a glass of milk, and some cheese. And that would be approximately 1,200 milligrams per day. So for residents who are at high risk for fractures, who can't meet that recommended daily allowance, so maybe you are lactose intolerant or have difficulty eating a lot throughout the day, and it's hard to meet that dietary minimum, then we recommend daily supplements of calcium up to 500 milligrams per day. And so really we want people to try to get as much calcium from the food they eat as possible, because that we can use that calcium a little better and there's less risks associated with it. But we understand not everybody can achieve it with their diet. So instead, you could take a supplement if necessary, especially if you're at high risk. But for residents who are not at high risk, we suggest this supplement instead. So the evidence is not as clear for people who are not at high risk. So the recommendation is not quite as strong. But if you're at high risk, you should definitely be, and if you're at high risk and you can't achieve that calcium through your food, then that's where a supplement should be considered. So as I mentioned, foods that are high in calcium are usually also have dairy. So things like milk, cheese, and yogurt are really great. But most alternative beverages to dairy products are usually fortified as well. So things like fortified almond, rice, or soy beverage are also okay. Or if there's a yogurt or cheese, as long as they're fortified as well. And fortified just means that calcium and vitamin D have been added to them. Also, orange juice is often fortified as well. So you can look into that and ask the nutrition department as well whether the orange juice you are drinking has been fortified. And then other foods also have calcium. They're just not quite as high. So nuts like almonds, broccoli also has calcium. You just won't get quite as much. So these are foods that are high in calcium. What about vitamin D? So for residents who are at high risk for fractures, we recommend, so a strong recommendation, of daily supplements of 800 to 2,000 units of vitamin D, and D3 is usually the easiest one to absorb. And for residents who are not at high risk, it's a suggestion, so it's not quite as high. The evidence is not quite as strong for residents who are not at high risk for fracture. What about for exercise? So for residents at high risk for fracture, we suggest balanced strength and functional training, and this should be part of a multifactorial intervention to prevent falls. And why it needs to be part of a multifactorial intervention is when we looked at all the studies together, we found that if they only included exercise for people who are at high risk, people were actually more likely to fall. So exercise needs to be part of the bigger picture. So ensuring that there's calcium, vitamin D, hip protectors are worn, making sure that the environment is safe so there's not things to trip over, the floors aren't slippery, those types of things. Making sure you're using a cane or walker appropriately, or maybe you don't need one. And so making sure all of those strategies are in place to help prevent falls and fractures. And then for residents not at high risk, we suggest the same things, but you don't have to be quite as worried about it being part of a multifactorial intervention. So what could exercise look like? So we talked about functional strength training. So this is an example of one exercise that's a really great functional strength training exercise. And it's basically practicing sitting, going from sitting to standing. So sitting in the chair and then standing up nice and tall, and then sitting back down and controlling that sitting motion so that you're not just kind of plunking down in the chair, but taking your time and sitting down nice and slow. And the nice thing is you can do this throughout the day. So if you're waiting in the dining room, you could practice some sit to stands, or if you're waiting for an activity to start, or before you go down to the dining room, this is something you could do potentially on your own, but you want to talk with your physiotherapist or your exercise provider and make sure it's safe for you to do. We also talked about balance training, which is really important for falls prevention as well. So this is an example of a walking balance exercise. So walking in parallel bars, or holding onto the hallway if you have a railing, and practicing walking in different ways. So it's kind of hard to see in this picture, but walking on your heels, walking on your toes, walking on a line, all sorts of different ways to practice walking that incorporates balance training as well. And then what about hip protectors? So for residents who are mobile, so meaning that they are walking around by themselves and are at high risk for fractures, we recommend hip protectors. So as I mentioned, so this is a strong recommendation. The evidence does support the fact that they do help prevent fractures. I do understand that there's definitely some barriers to wearing hip protectors. They might not be comfortable, they're bulky underclothing, those types of things. But what I would really suggest is trying out a bunch of different types of hip protectors. So there's ones that you can just slip on. There's ones that are kind of like in a short or like an underwear type thing that you pull on. Different ones might feel better than others. So if you have the opportunity, you could maybe give a few a try. I know some homes will have some that you can kind of trial and then they'll wash out before you maybe purchase them. But then you can find a pair or kind that is good for you. For residents who are not at high risk for fracture but are mobile, we suggest hip protectors. And again, this is really, so it's a suggestion. It's not quite as strong, the evidence for them preventing fractures for people who are not at high risk. And I just want to point out, we do have some videos on our website. So if you have access to a computer and you want to look at some exercises, or you want to direct your care team towards some exercise videos, we do have some that you could check out. So we have one for personal support workers, one for physiotherapists and physiotherapy assistants, one for group exercise trainers, and one for people providing restorative care. And they're really short videos, they're just a minute or so, and they give some really quick tips on how you can help prevent fractures with exercise in long-term care. And then what about medication? So as I mentioned, residents who are at high risk should be offered, so it's recommended, it's a strong recommendation, and they should be offered osteoporosis medication. But of course, there's always pros and cons to taking medication. So you want to consider what are your preferences in terms of medication. There's oral medications as well as injections. What are the goals of your care plan? Also, some medications, if kidney function is an issue, there's different medications that are better for you. So you want to make sure that that is a consideration as well. And then life expectancy. So this one is always a little bit hard to talk about and a little bit hard to gauge, but I guess it kind of goes along with goals. So for osteoporosis medications to be effective, they have to be taken for at least 6 months to a year. And so life expectancy can play into this. And you might want to consider if it's a medication that you're willing to take you have to take for at least 6 months for it to see a benefit, for you to see a benefit. And then the other thing about medication is it's really important to identify any medications which may also be increasing the risk for falls. So this would be things like hypnotics or sleeping medications that make you kind of dizzy or lightheaded or a little bit out of it. They might increase your risk for falls. Of course, there's good reasons why you might need to take them, but you just want to identify any medications that might be able to be stopped or maybe changed to a different medication. So this is another important thing to do. And then for residents at low risk, I went through a few of them already. The evidence is not quite as clear, but we suggest for pretty much all of these the same things. The only thing that's really different is medication. Osteoporosis medication is not usually prescribed for people who are at low risk, but all the other things are still important to consider. So getting enough calcium and vitamin D, exercise has benefits beyond just preventing falls and fractures. It can increase your mood, and it can prevent things from getting worse. So you can still be able to walk around and move around or transfer with less help. Fall prevention strategies are always important. And then working together as a team to really work towards your goals and your care needs are definitely important. So I just want to point out that on our website, we have lots of information. We have a fracture prevention toolkit with all sorts of resources that are free. So your residence council is welcome to go to our website and download any of these tools that are free. So we've got information about the fracture risk scale. We have tools and resources. We have our guidelines all written out for you. Different videos about exercise, but also about living in long-term care. We have information for residents and families, which I'll show in just a second, but it's all there and it's all free. So feel free to go and download and print them out, put them up around your home or share them with other residents or your family members. I'll just point out, we do have some other tools for healthcare providers. So for example, the safe administration tool, which talks about medication. We have a little bit of a flow chart for fracture prevention and fracture prevention order set. So this kind of goes through all the different things that are really important to look for. So you could point your healthcare team towards this as well. As I mentioned, our video series is also on there, so you can check that out. And for residents and families, we do have some tools as well, and these were developed in association with the Ontario Association for Residence Councils and Family Councils of Ontario. The first one is a talk sheet called Keeping It Together, and it basically gives you some tips on starting the conversation about osteoporosis, about things you could talk about with your care team, with your leadership or administration within your home, and things you maybe want to consider yourself about osteoporosis and preventing fractures. The middle one is kind of like an infographic that identifies the things that are important for preventing fractures in long-term care. And then the last one is a quick summary of the recommendations for how to prevent fractures. So what I went through, it's just kind of summarized in one page for you. So again, you can download those from our fracture prevention toolkit. They're in the section called Families and Residents. And as I mentioned, these were developed in collaboration with the Ontario Association of Residence Councils and Family Councils Ontario. And so they're developed by resident representatives in collaboration with our team. So what are kind of the take-home messages for you? We really want to try to prevent fractures because they can cause a lot of distress and they can be painful, and there's something that's really important to try to prevent from happening. So you want to ask your care team about your FRS score to decide if you're low or high risk. So again, if you're between 1 and 3, you're low risk. If you're above 4, you're high risk. And then work with them to develop a care plan for addressing fracture risk that's going to help you reach your goals and meet your needs. So this would include things like looking at your diet, looking at your exercise, considering the medications that you're on, considering potentially wearing hip fractures, as well as looking at other things within your home that might help prevent falls as well. And just to highlight some of the other things we're working on is right now we just wrapped up a project where we're automatically linking those treatment recommendations that I had to the FRS score, and it's called a clinical assessment protocol. And basically it will help your care team. They won't have to kind of think or go through a whole bunch of pages or flip to other things. It will say, this person is FRS, their score is 4. So these are the things that you could think about implementing in their care plan and talk about them with. So it will kind of automatically link those things so they won't have to go searching. And then the other thing is we're developing a version of the FRS score for people who are receiving home care. So people still residing in their house, but they're having potentially nursing or personal support workers come into their home to help provide care. So we realized this is another population that is at high risk for fractures. So we want to take the FRS score over to that population so it can be used there as well. So those are two of the things we're continuing to work on. So I just want to acknowledge all of the people who have helped us develop these recommendations and develop the fracture risk scale. So Osteoporosis Canada, as well as the Ontario Osteoporosis Strategy, Hamilton Health Sciences, Point Click Care, which has helped us get it into the electronic medical record, the Ministry of Health of Ontario, McMaster, as well as Interi and the University of Waterloo, and then the Family Council's Program of Ontario and the Ontario Association of Residents Councils. So we've had the opportunity to work with all of these great people, and it's really helped us get fracture prevention out to you, the residents of long-term care. So I'd like to thank you for your time today and for listening to me. I'm happy to answer any questions, and my email address is on the right-hand side there if you have any questions that pop up later, or if you have any thoughts or things you want to share with me, you're more than welcome to send me an email at any time.
Thanks, Caitlin, very much for being with us today. There are a few questions in our chat box that I can relay to you. First question is from Matthew. Can you please list the MDS sections that will trigger the FRS? I'm not sure if you have that information at your fingertips.
Yeah, I don't have it at my fingertips, but I can definitely, if you email me, I can definitely send you. So I'll just go back to this slide. Sorry, let me just quickly flip here. So if we go to here, so these are all the items within the MDS that will trigger it. I don't have the item names or the sections listed here, but these are kind of the word version of the item. If you want the actual like item code, like K2B or whatever, you could just send me an email and I can send you that list, because I don't have them all memorized, unfortunately.
No problem. So Matthew, if you are still on the line, if you wouldn't mind sending a follow-up question to Caitlin's email, she could give you the specifics. The next question is from Monique. It's in regards to the exercises. She says, it has been observed that once a immobile resident develops some strength that improves their mobility, they tend to attempt unsafe self-transfers, increasing risk of falls. That way, exercises may result in increased falls risks as well. And she just wanted to know your thoughts on that.
Yeah, so I definitely agree. So if we go back to here, so that's especially why we suggest is we recommend. It's not as strong of a recommendation, and that people who are at high risk of fractures and falls, it really needs to be part of a multifactorial intervention, so not just exercise. So looking at changing the environment as well. So maybe there needs to be more supportive assistive aids placed around so that they have something to hold on to if they're trying to transfer. Maybe we need to look at gait aids. Maybe we need to look at maybe there needs to be more supervision for a short period of time as strength increases. So yes, I definitely agree, and that's why it's suggested that exercise be part of a multifactorial intervention to prevent falls, not just by itself, because it can, as you pointed out, increase the risk of falling, especially for those who are at high risk already. So it's important, but it needs to be part of a bigger picture. We also know, so there's been a lot of research done around exercise and falls, both for people who live in the community and for people who live in long-term care. And we know that in the community, exercise by itself prevents falls, but in long-term care, exercise by itself does not prevent falls. So it needs to be part of that bigger picture for sure.
Okay, great. We have two questions that have come through from Angie Lamb. The first is, are you going to be developing the FRS score for the Medicare software, or is it strictly for the point-click care software at this time?
Yeah, so we are working to get it into homes that use other electronical medical record vendors. We kind of targeted point-click care because they work in most homes. We recognize they don't work in all homes. So our next step is to try to get work with the other vendors to integrate it in there fairly soon, within the next, I say soon, but it's within the next 5 years. So maybe it's not that soon. It depends on your perspective. The homes will likely be transitioning to a newer version of the MDS 2.0 assessment in Ontario. And so once that happens, it will automatically be in there for every single vendor. But right now, it's just in point-click care. And as I said, we're working on it. So I can't really give you a timeline, maybe 1 to 2 years for the other vendors. It's just a little bit more challenging because we have to go to several different people. So we're working on it.
Great. The second half of Angie's question was wondering if there's a way to calculate the FRS score manually. So
yeah, so you have to go through their MDS assessment. There definitely is a way to do it manually. It's not pretty, and it's not super easy, but I can definitely walk you through that. If you send me an email, a follow-up email, I can walk you through the steps to do that.
Okay, we have another question from Karen. It appears as though some residents who are frequent fallers have a lower FRS score than those who have not fallen in the past. I'm not sure if you could speak to why that might be the case, or.
So we go back here to here. So if they haven't fallen, then those who have not fallen. So if they've fallen recently, like in the past 30 days, they should be high risk. They would fall into this group here, like 4, 5, 6, 7, 8. If they've not fallen, then they would be low risk. But if they have fallen, they should be high risk for sure. So I'm not sure if that's that you've looked at the FRS score and you've seen that frequent fallers have an FRS score that's lower, which there might be something going on with the calculations. If they've fallen recently, which I assume a frequent faller has, they should be high risk. It might be other characteristics that, no, definitely if they've fallen, they should be high risk. So there might be something going on there.
Okay. Karen, if you have any follow-up questions, or if you want to get into some of the specifics with Caitlin, feel free to email her to speak in real time, and she can walk you through that. Our next question is from Debbie, wondering about getting a copy of your PowerPoint presentation. Now, you should see under your toolbar, there's a section that lists materials, and it is attached as a PDF. All of Caitlin's slides today can be accessed there. And as she did mention, and maybe you can zip back to that slide, Caitlin, a lot of the discussion is summarized in a kind of a fact sheet format that can be printed and shared at your homes. There it is. There it is. Yeah. So that is on the Jarrah Center website for your reference, if that's an easier format, or to supplement the slide deck. I also wanted to point out, as the OARC team supports residence councils, the sheet in green is a great way to really start a discussion at a residence council meeting or in a peer support group to have that conversation about osteoporosis. So we often do distribute that green sheet on the left of your screen there as well with residents. So that might be a way to bring the discussion of osteoporosis back to your peers, and perhaps your residents council is the right forum to do that. We have another question from Karen. Some residents who are predominantly in wheelchairs self-transfer and their FRS score is low. However, the resident falls frequently. How come there's this discrepancy? Oh, I think Karen's just elaborating on the question. Yeah.
Yeah, so that person would, if I just go back to the flow chart here, here it is. So if they predominantly use a wheelchair, so they would be unable to walk, but they would have had a fall. So they would still fall into this, the category 4 to 8. So they'd only be low risk if they were unable to walk. So predominantly used a wheelchair and they hadn't fallen in the past 30 days, they would be low risk.
Okay, so it's just kind of interpreting the score. And I also wanted to highlight, we do have an article in the latest Seasons magazine, which is a publication from OARC, which is a magazine that is mailed to every residence council across the province. So every home will have a copy. We do have an article about the fracture risk scale for your reference, getting into a little bit of an overview of the tool itself and its applications for long-term care. So I would urge you, that's another way you can learn about the tool and perhaps have a discussion about it in your homes. So, are there any other questions for Caitlin? You're welcome to unmute your line or to type through to me in the chat box. I have got one more written down for you, Caitlin, to put you on the spot.
No problem.
I was wondering, how might we engage residents living in long-term care in exercise, especially those living with cognitive changes? Is there any suggestions for meaningful exercise and really to engage those residents?
Yeah, so definitely with cognitive impairment, it can be hard to follow, follow directions, or kind of get distracted or whatever it may be. So a few recommendations I have are, first, try to exercise in a location that's not, doesn't have a lot of distractions, so not a lot of people walking by, or other activities happening kind of over there, so you can kind of see them. You want to be more in an enclosed space where it's quiet and exercise is the only thing that's happening, if possible, or at least maybe in a quiet corner of the home. The other thing is to keep the exercises really functional and things that people would have done in the past. So the example I use or a couple examples are, instead of asking somebody like to do a squat, for example. So I know what a squat is, other people know what a squat is, but maybe somebody living in long-term care might have never done a squat in their life, not know what it is. And then, you could go into elaborate descriptions of what that is. Okay, I want you to bend your knees and pretend like you're sitting down. Just have them sit down and stand up. So do that sit to stand exercise. I want you to sit down, and now we're going to stand up. And then you can always use something like a song to help it go faster or slower, whatever you want to work on. Or, for example, have people practice picking things up off the floor if their balance is okay, because that will challenge balance and it's something functional to do. You're practicing bending over. Or, for example, having somebody reach towards a sticker on the wall or a picture on the wall or something on the wall, so that you could practice things like calf raises or going up on the balls of your feet, going on your toes. And instead of saying, okay, I want you to lift your heels off the ground, that kind of thing, you're just asking somebody to reach for something. You could do something like, if you want to work on some strength, like a loaded carry, where you have people holding something heavy and walking with it, just asking them to hold a bag with weights in it, or sandbags or something in it that adds some weight. I want you to carry this bag from here to over there. And that's all you have to say. So making it something functional. And especially if you can find something, an activity that they did in the past that you can relate it to, that's always a good thing as well. So if they used to do farming, or they used to sew, or they used to, maybe they were a figure skater or something along, or a dancer, if you can relate it back to that, that's always a good strategy as well. And then keep instructions really simple. So I want you to sit down, and now I want you to stand up, instead of, you know, okay, bend at your knees and bend at your hips and go through like this crazy description of what you want them to do. So just keeping it simple and functional, and then in a quiet space.
Thanks, Caitlin. Those are some great suggestions. And I think we're nearing the end of our time together, and I don't see any other questions popping up. So on behalf of myself and the OARC team, thank you so much to Caitlin for being with us today, for sharing these exciting resources, and for your really thorough explanations about how this tool can be helpful in long-term care. So
Awesome. Thanks so much for having me.
And anyone who would like to share this education with their residence council or team members, it will be recorded, or it is being recorded, and you will get a link so you can listen to the archived webinar after today's session. So thanks again, Caitlin, and thanks everyone for joining us. Have a lovely afternoon.
Thank you. Bye.
Bye.